Well, good evening, everybody. Wassalamu alaikum wa rahmatullahi wa barakatuh. It's a pleasure to be here this evening to discuss acute coronary syndromes. Our program today is going to cover the management of acute coronary syndromes per local protocols. We're going to cover the ST elevation MI and non-ST elevation MI guidelines. With us today and joining me is Dr. Samih Lawand. He is the head of the Department of Cardiology at Dilla Hospital in Riyadh. He is going to cover the ST elevation MI guidelines per the Saudi guidelines. He is an active member of and has joined the task force of the Saudi Heart Association for the elaboration of ACS guidelines. He's also published and presented as faculty in this area of expertise. Following that, we're going to have Dr. Muhammad Abdul Zahir. He is also a consultant interventional cardiologist in Dammam Dhahran Medical Complex. He will cover the non-ST elevation MI. Once again, his expertise is in the field of ACS, and he has been faculty in multiple international and national programs. So without further ado, I'm going to lend the microphone to Dr. Samih Lawand to go ahead and start us off with the ST elevation program.
Assalamu alaikum, Dr. Mervat. Thank you for the introduction. And I'd like to thank the Saudi Heart Association as well as our sponsor, AstraZeneca, for allowing me and giving me the opportunity to talk about management of acute STEMI, the local and international guidelines and management plans. Did I share? I think so. Okay. Same problem is happening, so I cannot move the screen.
So try to put the cursor in the middle of it, and then press.
This is what I did. Okay. Bismillah ar-Rahman ar-Rahim. My agenda will include definitions, risk factors, and cardiac care in the setting of STEMIs, through which I will embark on managing the guidelines as per se since like the last few years. Now, as you know, all the thin vulnerable fibrous plaque is very much responsible for the rupture that is encouraged by large lipid core within the vessel wall. And when this time of a moment of rupture, it happens based on the balance between the intra-plaque pressure and the vascular lumen pressure, then the rupture would happen. A thrombus will form, usually at the weakest area at the junction of the plaque with the rest of the vessel wall, and then a thrombus will develop, allowing in the acute STEMI for complete occlusion of the vessel. Our Middle Eastern data as collected in this paper published in the Clinical Cardiology Journal, stated, as we all expect, that age, past aspirin use, dyslipidemia, diabetes, smoking, renal insufficiency, obesity, prior CAD, hypertension, and prior revascularization all are important risk factors contributing to the process. What we know about our own region and the fact that we are different from the rest of the world is well illustrated in this scheme showing the paper from Zubayd and his colleagues that talked about how young our patients, like you can see that the Gulf area average age of acute STEMI is around 56, which is about 10 years younger than the rest of the continents. Also, our time to getting the revascularization process is much longer, up to 178 minutes compared to the rest of the world. As you know, there are short-term and longer-term risk factor elements within the acute STEMI patients from time of the event, anywhere from the first 30 days, of course, then extends to the 6 months and also extends within 5 years to continue showing reduction in survivability. In part of diagnosis. As you know, the process of diagnosing ACS starts in the emergency room, where we recognize the symptoms, we assess the pain, we evaluate it, we decide whether we are anywhere between unstable angina, non-STEMI, or STEMI. But the goals are actually, more importantly, are dedicated to separate between those that are considered non-cardiac, like could well be very serious, like aortic dissection or gastroesophageal refluxes or costochondral inflammatory issues. But within the cardiac conditions, we have the so-called other cardiac conditions like myocarditis or inflammatory disorders, and also the so-called ACS or acute coronary syndromes, whereby the three most important definitions of acute events occur anywhere from unstable angina to non-STEMI to the STEMI. Of course, the diagnosis of particular importance is the presence of an XT elevation, myocardial infarction. And once this is shown, and along with the help of myocardial biomarkers, you will see that immediately other elements of positivity can contribute and diagnose. So along with the ST changes, positive troponin or other cardiac markers will highly depend on the ECG changes. And also when negative and no ECG changes, we may have to consider diagnosis of other than unstable angina. As you see it here, when it is negative, possible unstable angina can be anywhere from chest pain observation units to help make a better diagnosis. And it can distribute patients between being discharged on the basis that this ECG or lack of biomarkers and negative stresses are non-cardiac, while those with pains and positive follow-up ECGs or myocardial markers will, or stress tests will eventually being admitted in the same manner as we should do with the likely unstable angina, non-STEMI, and STEMI patients. Now, in 2017, STEMI management protocols that were published based on data collected since 2011, the presentation of patients with ischemia had to follow a flow chart for time to reperfusion, and a strategy to be followed anywhere from the time of onset of chest pain. Within that limit of time, we have what we call the patient delay, then beyond which the AMS delay from calling the AMS to the time of arrival of the patient to the hospital. It could be anywhere from a non-PCI center to a PCI center. If it were that the patient arrived in a non-PCI center and an ECG is done within 10 minutes of arrival, then we have to estimate two possible scenarios. One is that the duration of time up to which where the patient would actually arrive into a primary PCI strategy. If it were less than 120 minutes by estimation, then the patient should be followed by a reperfusion until wire crossing strategy. We call it the primary PCI strategy. If, however, the estimated time to PCA exceeds 120 minutes, then a strategy of fibrinolysis should be followed. And then after fibrinolysis, another reperfusion scheme should be followed, whether it is urgent or delayed, and that has its own pathway. Now, if it were that the patient arrives at a PCI center, then within 10 minutes an ECG has shown ST elevation changes, then a primary PCI strategy. And with that time limit of less than 60 minutes, wire crossing should be achieved, and then reperfusion. The strategy then follows as follows. Let's say a primary PCI strategy is considered, then a patient will have to be crossed within, as I said, 60 minutes, total 90 minutes, but within 60 minutes from arrival. And then beyond that, the patient will have to be treated as with hospital protocols to consider. However, if it were more than 120 minutes and the fibrinolytic therapy strategy is adopted, a bolus of fibrinolytic therapy and what we call is pharmacoinvasive strategy should be followed, and transfer to PCI center has to be followed within the 60 to 90 minutes in order to get to the PCI center. And there, a time limit can be considered based on the response to the thrombolytic regimen. If it were successful, then you have up to 24 hours to do the intervention. But if it were, then a rescue intervention has to be considered. Now, this is how it is clocking. From 0 time, all these indicators are class 1 indications for ECG, alert cath lab, aspirin, oxygen, if oxygen is less than 90, there is no benefit from using oxygen if it were higher. And then to the next step of using the so-called high impact antiplatelet therapy, including prasugrel or ticagrelor loading, and also to the other adjunctive medicines like beta blockers for tachycardias and or opioids as a tranquilizer. Of course, class 1A is to use radial access, as it has been shown lately, and of course the use of antithrombins and 2B3A inhibitors, anywhere from 2A classes with a low level of evidence, and then of course the class 1A use of drug-eluting stents. Within the 24 hours after, the patient can be either transferred back to the PCI center, a high-dose statin should be used, a non-RI PCI within hospital stay. All of these are anywhere from class 1 to class 2A indications with ample evidence. And the use of beta blockers, ACE inhibitors in those with or without ejection fractions, anywhere from lower than 60 to lower than 40, and then adjusting the treatment as necessary based on the left ventricular ejection fractions. And of course, when we talk about ACE inhibitors, now we are also talking about ARBs and ARNIs. And within the next period of time, then the ticagrelor or prasugrel versus and aspirin, as we call the DAPT therapy, and then imaging for what you call viability for patients with ejection fractions less than 40, all should be adopted. And up until discharge, and then within 6 to 12 weeks, up to 1 year when the dual antiplatelet therapy has to be reduced to SAPT or single antiplatelet therapy, and then other strategies can be considered in different bleeding setups. Now, this is just to show you how we should, what you call, follow the time schedule, anywhere from 0 to a month to 6 months to 12 months. In the case of what you call PCI, whether it is a bare metal or drug-eluting stent, a class 1 indication has to be that we use clopidogrel or prasugrel ticagrelor for 12 months. But it can be made shorter if, as long as it can be 12 months, as long as no high risk of bleeding, but can be shorter down to 6 months if it were a high risk bleeding. Now, this is the strategy to intervene and to treat. And the evidence is based on Plato. Plato is a landmark clinical trial proving the superiority of ticagrelor in reducing the mortality and versus clopidogrel. And it was over 18,000 patients divided equally between Brilinta and clopidogrel. All patients were acute coronary syndromes, and the outcomes were based or measured by primary efficacy outcomes, anywhere from cardiovascular death, MI, strokes, silent or otherwise, and primary safety endpoints using special Plato measure bleeding. And this is all was based on so-called the diagnosis, STEMI, non-STEMI, or unstable angina, or by management strategies, whether it is invasive or non-invasive, and as well based on what you call patient characteristics. Of course, the ticagrelor absolute risk reduction was so early, within the first 30 days, and extended up to 12 months. And this has shown with an absolute risk reduction of 1.9% and a 16% relative risk reduction for the primary efficacy endpoints. But this is within anywhere from 30 days to 12 months. And for the secondary efficacy endpoints, the overall plateau study have shown ticagrelor demonstrated 21% relative risk reduction with an absolute risk reduction of 1.1, and this is over 1 year. For the Stemi subgroup, also in the ticagrelor 90 milligram twice daily demonstrated a 17% relative risk reduction in cardiovascular mortality and a 1% as absolute risk reduction. And at 12 months, no significant increase in total major bleedings, although some bleeding did occur, but at least there were no so-called intracranial bleeding enough to consider this as what you call as a negative impact. But overall, the non-cabbage related major bleeds were a little increased, and cabbage related major bleeds were not, while major or minor bleedings were increased. Now, the subgroup Stemi itself, you will see that the overall from 6,900 plus patients that were recruited within the trial, those who received Brilinta compared to clopidogrel had no difference of outcome events in terms of events. Stemi reperfusion strategies, when fibrinolysis was considered, were also assessed. A primary PCI is recommended, as I said, when the timing is less than 120 minutes to reach the hospital, and fibrinolysis when it is more than 120. The guidelines with respect to the fibrinotic therapy strategy was that a fibrin-specific agent was to be used, and this is a recommended treatment. All of this based on class 1 indication. Half-dose tenecteplase can be used if the age is above 75. So the age cutoff is important to be respected. With the addition of an antiplatelet along with the fibrinolytic, anywhere from aspirin to clopidogrel has been adopted. And in fact, the guidelines have not yet addressed the introduction of either ticagrelor or prasugrel into the post-thrombolytic treated patients. Now, following fibrinolysis, emergency angioplasty and PCI is indicated in patients who are in heart failure or shock. Also, rescue PCI is also indicated in those patients who do not achieve what we call less than 50% ST segment resolution within 90 minutes. Angiography PCI of the infarct-related artery is also recommended. And this is within 22 to 24 hours. Emergency angiography and PCI, if needed, is indicated when ischemia do recur or reocclusion after initial successful reperfusion. Now, within the successful fibrinotic strategy is basically the same. We have to use all the class 1 indicators within the 0 to 10 minutes time for all necessary and conjunctive treatments that I mentioned earlier. Then up to 2 hours, we have to alert and transfer within that time period to the PCI center. All of these are class 1 indications. And then between 2 hours and 24 hours, based on what the patient might be in response to the thrombolytic treatments, then a PCI has to be considered. And also with an IRA and a non-infarct-related artery within the hospital stay, and also use the same adjunctive therapies that I mentioned earlier to be extended up to 1 year, as I mentioned before. Now, reperfusion after fibrinotic therapies have been addressed by the guidelines, whether the European guidelines who talked about aspirin, P2Y12 inhibitors, clopidogrel in particular, and divided them by age. age of less than 75 and age of more than 75. No loading dose for those age more than 75. The Americans also talked about IV aspirin, clopidogrel, and the need for DAPT. Also considered that at 48 hours after fibrinolysis can switch to ticagrelor. The basis of that was because of the newer study that addressed this issue. Now, the new evidence. This study, basically so-called the TREAT study group, have addressed the issue of using ticagrelor in the post-thrombolysis period. They used what we call a median of 11.4 hours after fibrinolysis and found that the comparison between those who received clopidogrel versus ticagrelor, there was non-inferiority was achieved, and thus no difference in the bleeding outcomes when it's used. Now, the so-called reperfusion in PCI-capable hospital has to be based on the following three important issues. One is primary PCI should be performed in patients with a Stemi when ischemic symptoms within the first 12 hours. Primary PCI should be performed in those with ischemic symptoms of less than 12 hours duration who have contraindications to receive fibrinotic therapies, and primary PCI should be performed in the Stemi and cardiogenic shock regardless or irrespective of the time delay from MI onset. So the 12 or 24 hours by themselves do not put a hold or do not interfere with the decision towards reperfusion. Now, those the post-procedural anticoagulant therapies are also mentioned. Again, this is published in 2017, talking about potent P2Y12 inhibitor, unlike the previous guidelines, and or clopidogrel if the potent are not available, and aspirin, 2B3A inhibitors, and cangrelor, which is the intravenous form of ticagrelor, also is to be considered, but at a lower level. Now, the anticoagulant therapies for all patients, in addition to antiplatelets, routine use of unfractionated heparin, in patients with heparin-induced thrombocytopenia, bivalirudin, routine use of enoxaparin should be considered, routine use of bivalirudin should be considered, but fondaparinux is not recommended for primary PCI patients. Now, again, back to the recommendations, the American recommended reperfusion therapy should be administered to all eligible patients, and all this with regards to primary and fibrinotic therapy in the absence of contraindication should be administered, again within the limits of the 120 minutes that I mentioned earlier from first medical contact. And the Europeans also contributed similarly to the reperfusion indications within less than 12 months. And if timely PCI cannot be performed, then thrombolysis, etc. Now, how to basically both Europeans and the Americans agreed to the aspirin P2Y12 and divided them as per the use of the newer high impact so-called P2Y12 inhibitors like ticagrelor, and specified their role along with the DAS and also BMS placements. And this is applied to the Americans as well as to Europeans, but the Europeans were more importantly stressing the point of potent P2Y12 inhibitors as opposed to the Americans. And here in this American guideline, they talked about recommendations for P2Y12 inhibitors, which is basically a class 2A, what we call using the DAPT for STEMI patients with stent implantations, and a class 1 recommended in patients with ACS treated with DAPT, OPMS or DAS, P2Y12, to be given at least for 12 months. Now, all guidelines have contributed in a way or another. The 2016 American College and AHA guidelines have also contributed to the use of potent P2Y12 inhibitors. The Europeans, 2017, have also indicated their recommendation to use a potent P2Y12s. And in 2017, the switching between P2Y12 inhibitors was also addressed because of the development of so-called higher bleeding risk that can occur beyond the first month of the intervention. And these patients who might expose themselves to higher bleeding risk, or the opposite, or those patients who have a higher ischemic risk beyond the event, then a scheme of switching anywhere from clopidogrel to prasugrel or the reverse, prasugrel to ticagrelor or the reverse, anticoagulant to clopidogrel or the reverse. The timetable for prasugrel is 24 hours, and for ticagrelor, clopidogrel is just no respected time interval is necessary. Based on that, all these changes should be considered, especially in the acute setting. So always reload in the acute setting. Now, of course, more 2018 European guidelines have also emphasized the P2Y12 inhibitors as well as a class 1, and also that in severe bleeding risk that we should reduce the duration to 6 months. And of course, we cannot ignore the fact that our most recently published Saudi Heart Association guidelines in December 2020, that I had the honor to be a member of it, that has also indicated the need for ticagrelor, and it is recommended for that. Now, just to talk about what had happened in the 2030 ACS consultant group, that they came up with this highly important guidelines, is I selected these two images of the approach that was considered. The approach was basically designed to address what we call the hub and spoke concept. The hub and spoke concept selected, as you see on my right side below, that King Saud Medical Center, King Fahd Medical Center, Medical City, Prince Mohammed bin Abdulaziz, and KKUH, King Khalid University Hospitals, were selected based on readiness assessment tools that use several of these elements, for classic elements required for that. And patients and hospitals otherwise were attached to these four major institutions called the hubs, and then spokes were accounted for based on the also criteria for the availability of the cath lab. And I don't have much time to go through the details, and of course, whether they are a spoke with a PCI capability or a spoke without a PCI capability. The most important scoring system was adopted. We call it the heart score, whereby anything more than 3 to 4 points accumulated would have considered the patient as a higher likelihood of having an acute coronary syndrome. And this is based on history, ECG changes, age, risk factors accumulating, troponin elevations. And these are the elements of points that were used to account for the scoring. And in this schematic presentation, you will see up to 3, the risk will not be requiring any hospitalization. The patient can be discharged from the hospital, and these are you're representing about 1/3 of the patients, and their mortality, their MACE, their events, all are very low. And then the other group, which is the intermediate risk group, 4 to 6 points accumulated at the heart score, could have to be observed and then risk assessed by admission and workup of presence of absence of ischemia. And of course, the most important, which is less than or up to 10% of the population who would have, who represents about 17% of the total, who would have higher MACE, higher death rate, and observation treatment with coronary intervention is to be considered. Now, what did the reperfusion therapy state as per the Saudi cardiac recommendations in acute coronary syndrome? Reperfusion is indicated within 12 hours. As we know, primary PCI is to be preferred over fibrinolysis. It is recommended that Stemi network target a total device, so-called FMC to device time, not exceeding 120 minutes, and that the time between registration of the patient in non-PCI capable hospital also, or what you call door in to door out, should be within less than 30 minutes. We recommended a target FMC to device time of less than 90 when we go to a PCI capable hospital, and for patients with contraindication to fibrinolysis, transfer for primary PCI should be initiated as long as the time is expected to be longer than 120 minutes, and the routine primary PCI surgery should be considered within 12 to 48 hours after onset. In asymptomatic patients, routine PCI have an occluded IRA of more than 48 hours after the onset of Stemi is not indicated. Asymptomatic, longer than 48 hours, and occluded primary infarct-related artery is not indicated. The time frames for the diagnosis in the emergency room up to management is established well. As you know, this is based on similarly on guidelines directed time frames, anywhere from first medical contact within 10 minutes, diagnosis when it's based on ECG within 10 minutes, door to in, door out within 30 minutes. This is all in the emergency room, by the way. Transport times, inter-hospital transfers, less than 60 minutes. Time from arrival to catheterization lab to the first device activation is less than 30 minutes. Total time from the first medical contact to first device activation, less than 120 minutes, and total time from first medical contact to the first device activation for patients with PCI capable, the first one was non-capable, is less than 90, and time delay from start of fibrinolysis to angiography should not be more than 2 to 24 hours after fibrinolysis. Now, what are the clinical situations that I selected? A few. The preferred vascular access should be radial access, and the data is importantly accumulating and very clear about the reduced bleeding risk and ease with which the patient accepts the procedure. And this has to be with certified or at least experienced radial access operators. In the STEMI patient with cardiogenic shock, immediate PCI is indicated for craniotomy is suitable, undertaken less than 120 minutes. Fibrinolysis should be considered in patients with in patients with cardiogenic shock, and primary PCI strategy is not available within 120 minutes from STEMI diagnosis, and clinical complications has to be ruled out. And then if mechanical complications are present, then they should be treated as needed. And in this situation, an emergency or an urgent echo should be done to assess this possibility. In patients with cardiogenic shock and multi-vessel disease, within the hospital, say it is recommended to finalize all the IRAs, but the IRA vessel in cardiogenic shock is routine revascularization of the non-RA is not recommended. So in the acute setting, it is not recommended, but within the hospital stay, it is recommended. Now, in asymptomatic patients, a routine primary PCI surgery should be considered in patients presenting late after symptom onset. But in asymptomatic patients, anywhere from more than 48 hours and routine PCI of an occluded IRA, it is not indicated. Now, a same-day transfer of a non-PCI capable hospital to a PCI capable hospital, that should be considered appropriate to selected patients after successful primary PCI, and those without ongoing myocardial ischemia, then patient can be transferred back to the hospital that the patient has been sent from. Recommendations regarding imaging and stress testing in patients during hospital stay Routine echocardiography within 24 hours has to be done. LV and RV functions should be assessed. And if it is an emergency, like a hemodynamically unstable patient, it has to be urgently done. Now, regarding other clinical situations, patients with multivessel disease should all non-infarct related arteries be revascularized, and the recommendation is non-RAA lesions should be considered before discharge. In STEMI patients, should thrombectomy devices be used? And the answer is routine use of thrombus aspiration upfront strategy is not recommended. We do use it occasionally, but it is not highly recommended because of higher risk of stroke. And the STEMI patient with should coronary artery bypass grafted should be used, should be considered? Yes, if jeopardized myocarditis is large and the IRA cannot be performed by PCI, yes, can be considered. The use of percutaneous left ventricular assist devices, only one negative aspect of it is that routine use of intra-aortic balloon pump should not be encouraged. Now, in the adjunctive therapy part of the reperfusion, aspirin, ticagrelor is to be used as I stated earlier in my presentation, with the loading dose that we all know about, and then followed by either adopting ticagrelor, and if ticagrelor not available or contraindicated for any reason, clopidogrel, etc. All of this within up to 12 months, and unless there are contraindications like high bleeding risk that I mentioned earlier. Antiplatelet therapies at discharge, aspirin, clopidogrel, DAPT for up to 12 months. And again, unless excessive bleeding do occur, it can be made shorter. Now, preferred dual antiplatelet therapy are aspirin, clopidogrel in the patients with fibrinolysis. And the preferred anticoagulant therapy underlying primary PCI, we recommend routine use of unfractionated heparin. Preferred anticoagulant therapy in patients receiving fibrinolysis, enoxaparin. UFH can be used as a so-called weight-adjusted dose. Now, management of STEMI patients with stable or hemodynamically irrelevant ventricular arrhythmia, routine use of antiarrhythmics is not recommended. Asymptomatic hemodynamically irrelevant ventricular arrhythmia should not be treated. The long-term management of ventricular arrhythmia and risk evaluation for such like ICDs, etc., should be recommended, but not less than 6 weeks up to 3 months based on the event, if it is acute MI. Now, recommended antiplatelet therapy at discharge from hospital, aspirin, clopidogrel, DAPT, based on whatever we use, ticagrelor or clopidogrel, if ticagrelor is not available, again, up to 12 months, and to be shorter or contraindicated if it is with excessive bleeding should be shorter. Now, from a beta blocker point of view, in STEMI patients and who is not acute heart failure, the routine rules where beta blockers should be considered. For the ACE inhibitors, ARBs and ARNIs in STEMI patients in heart failure with a left ventricular dysfunction, ACE inhibitors should be considered in the absence of contraindications. For the lipid-lowering therapies, it is recommended to use high-impact therapies to lower the statins. It should be reassessed within 4 to 6 weeks after discharge, and LDL goal should be less than 1.8. I know that the latest guidelines have now dropped it down to 1.5 or less, but at least in this guideline, this is what we came up with after now, and this is considered important even after one high-impact anti-lipid therapy is used and this LDL is not achieving 1.8 or less or more than 1.8 remaining, then we have to consider other treatments, non-statin and even PCSK9. Lipid levels should be re-evaluated, as I said, 4 to 6 weeks after. And finally, the cardiac rehabilitation and structured secondary prevention programs should be adopted in high volume STEMI centers. It is recommended that secondary prevention measures should be undertaken. Recommend to identify smokers, and treat their habits, attend to cardiac rehab and understand and undertake structural so-called rehabilitation plans after their hospitalization. And it's recommended that patients be re-evaluated within a period of anywhere from 3 months up to 1 year. Within that period of time, a re-evaluation of their myocardial performance, of ischemia burden, and should symptoms do change, we have to readdress the presence or absence of ischemia. Now, a couple of messages about ticagrelor and clopidogrel labels, that fibrinotics within 24 hours of Brilinta using is to be addressed, as long as when it comes to the guidelines, it will be considered. But Twilights have trial, and also another French trial, the name of it is, I'm not remembering now. Both have said that the bleeding risk, if Brilinta or ticagrelor is given at least in a median of 11.5 hours or within 24 hours, is not inferior. Clopidogrel in ST segment elevation infarction patients should be loaded. And this can be done same whether it is with thrombolytics or without. And the special warning is about the presence of other elements like non-steroidals or COX inhibitors that could actually increase bleeding in the presence of aspirin, heparin, and 2B3A inhibitors. With that, I will stop here and thank you for your attendance.
Thank you, Dr. Lawan. That was a very comprehensive review of ACS. I think you very elegantly went through, the international guidelines, the regional guidelines, and so on. I'm just, just so we keep our audience engaged, I'm going to ask a few of the questions that came up, and perhaps you can address them. One of the things that came up was about pre-treatment. Do you like to pre-treat your patients with antiplatelets ahead of time? Do you like to define the anatomy first and then give the antiplatelets?
The trials that address this have talked about pre-treatment with prasugrel, which we don't have. That is a necessity. But all other patients coming to the cath lab, they don't have to be pre-treated. They can be treated on the table. If time allows, they will be treated in the ER, of course, but on the table or immediately upon finishing the procedure. And that has been addressed well. Now, those who are coming with non-acute coronary syndrome, it's a different story. Yes, we have to pre-treat them, and the same rule does not apply. So pre-treatment is not necessary in the acute MI ST elevation patients.
And who are the patients that you choose to give glycoprotein 2B3A inhibitors for?
During the cath lab procedure, we observe the burden, what we call the burden of thrombus formation, the size, the likelihood of that thrombus can pose a threat to the success of the procedure. One of the elements that contribute to the impedance or lack of success of our procedure is the duration from the onset of pain to the time of the procedure. Although we do recommend up to 48 hours, but those patients who come late are more likely to have thrombotic element more aggressive than the other thrombi, and thus treating these patients with 2B3A inhibitors on the table during the procedure with bolus given, like what I do is I give at least half the bolus intracoronary, especially in vessels that still have some perfusion. It is more likely to be successful, because those who are totally occluded, the benefit is less obvious. So thus, yes, 2B3A inhibitors remain necessary. But in those who come with acute STEMI and no obvious threat from a significant thrombus formation that estimated basically initially on angiographic findings, we don't have to use it, and it should not be used routinely.
And the final question is, you live in Riyadh, which is a very populated and a very crowded city. So, you spoke a little bit about the spoke and hub, setup. How do you see the future direction of streamlining primary PCIs and transfer from non-cath lab capable centers to cath lab capable centers and so on? What do we still need to work on to get there?
There's a lot to be worked on. First, once the spoke, so the hub and spoke concept is applied, don't forget, this is, for now, it's only applicable to the so-called public institutions, basically Ministry of Health. Now, the institutions that will be so-called the spokes of each of these hubs will be selected based on geographic location. And actually, unfortunately, I don't have the images, but basically the Riyadh has been divided into spoke hub areas based on these four major institutions. Now, the next step, once this is established and the ministry have already adopted the recommendation that has been forwarded to it, then the next step will be to include the private institutions and other non-Ministry of Health institutions to become either spokes or hubs based on their geographic distribution. Of course, they have to fulfill the criteria required by being a hub or a spoke, and then be divided into a spoke of either PCI capable or non-PCI capable. There's a lot of work to be done. Once the process of adoption is what you call is running, then we can probably find out all kinds of obstacles and needs, especially in the areas surrounding the city of Riyadh, where there are areas of where there are hospitals that lack even the presence of a cardiologist or even an assistant or a specialist that may contribute to the process. So there are a lot of issues that has to be addressed, but it has to be taken step at a time until we finalize a whole program addressing, and what applies to Riyadh will apply also to the other cities, of course. Better than
said, we have to start somewhere, and we'll find glitches along the way, and as we move along. So shifting gear to non-ST elevation myocardial infarctions and the guidelines. So we'll move on to Dr. Mohammed Abdullahir. The microphone is yours.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Today I will take you with a fast journey to discuss the guidelines or recent updates of the guidelines for acute coronary syndrome, non-STEMI. Actually, in just the last year, 2020, we have two updates in the guidelines. We have the national guidelines from Saudi Heart Association, and we have the European Society of Cardiology update. This is the first update since 2015, previous guidelines for acute coronary syndrome. So first of all, the best to start with is to set this general rule for all the guidelines, and this is written in the guidelines. The guidelines and their recommendation should facilitate decision making, not to take decisions. However, the final decisions concerning the individual patient should be made by the physicians or the heart team with consultation with the patient. And this is very important. Guidelines will facilitate, will guide us, but will not and should not take decisions. So let's review the most important topics covered by the National Saudi Heart Association guidelines. So first, we can discuss about risk stratification, because these kind of patients are a very heterogeneous group of patients, starting from acute coronary syndrome or unstable angina, up to patients with high-risk non-STEMI. So risk stratification is very important, and as shown in the national guidelines, that in patients with non-ST segment elevation acute coronary syndrome, a quantitative assessment of the ischemic risk by scores is superior to the clinical assessment by the risk criteria alone. And they advise to use the GRACE score, which is the most commonly used score in most of the guidelines, and it is very simple score. In the GRACE score, you can find this calculation with application in your mobile. It has simple 8 questions. These 8 questions are very easy to answer, like age, heart rate, systolic blood pressure, creatinine, whether the patient had cardiac arrest on admission, abnormal ST segment by ECG, abnormal troponin, and whether the patient has heart failure or no. By answering this short 8 questions, we can have points, and these points will give a calculated risk of the mortality within 6 months. This will help much by this risk stratification to answer the very important question, which is the timing for invasive treatment. In the patient with acute coronary syndrome non-STEMI, not all should be taken directly to the cath lab like patient with a STEMI. So what are the common scenarios we can get? Actually, the guidelines give us 3 scenarios. First scenario is to immediate invasive strategy. And by immediate invasive strategy, we mean that it should be within 2 hours from admission. This for mainly the very high risk patient like ongoing chest pain, hemodynamic compromise, arrhythmia, patient with mechanical complication of myocardial infarction. All of these should be taken directly to the cath lab or immediately within 2 hours. Second scenario is when we advise the patient for early invasive strategy. This early invasive strategy means that this patient should be in the cath lab within 24 hours of admission. And this includes the patient with high risk, with like high GRACE score, patient with positive troponin, or patient with dynamic ECG changes. And the third scenario for the patient with lower risk is delayed invasive strategy. And by delayed invasive strategy is meaning that the patient can be in the cath lab within 72 hours of admission. This may include the lower to intermediate risk patient, and some patients may need testing by non-invasive testing. The access for revascularization, as discussed with Dr. Samir, it's the same. It's in centers experienced with radial access. The radial approach is recommended, and we do believe nowadays as radial intervention saves life. Then the anti-platelet recommendation, which is the most hot topic among the guidelines recommendations. This is the recommendation by Saudi Heart Association recent guidelines. This table is very rich, and we can discuss this for more than hours if we need. So let's explore the guidelines recommendation for antiplatelet therapy. First, aspirin, as expected, is recommended for all patients without contraindication, regardless the treatment strategy. So aspirin is the baseline to treat this patient. Second, ticagrelor or clopidogrel, if ticagrelor is not available, they are not equivalent. So mainly ticagrelor is recommended, and before or at least the time of PCI. This means the pre-treatment. So the national guidelines advise the pre-treatment either before or at the time of PCI. Let's continue. And should be maintained over 12 months to 1 year, irrespective of revascularization strategy, 10 type, unless there is contraindication like high bleeding risk. So we have some questions about the pre-treatment duration. Is it should be 12 months for all or no? The most important questions and discussions open in this area of the antiplatelet therapy are the 3 questions. First, Pre-treatment, like the question we had, first question we had from the audience. Should I load my patient with P2Y12 inhibitor at initial presentation, or what is the best time for pre-treatment of my patient? Second, what is the best duration I should advise my patient to be on dual antiplatelet therapy? And third question, is the antiplatelet therapy is the only antithrombotic strategy to reduce the thrombotic risk? To go through these answers, we can dig inside this European Society of Cardiology Guidelines 2020, and we can find some answers and discussions of these questions. First question, the pre-treatment dilemma. And in this pre-treatment, we are focusing now on patients with acute coronary syndrome and non-STEMI. So what is pre-treatment? By definition, pre-treatment of anything, even not in cardiology, not a medicine, that is the treatment of something with a chemical before it's used, just prepare for use. So treatment of something with chemical before it's used. But in cardiology, we mean pre-treatment with antiplatelet is to give aspirin plus P2Y12 inhibitor before the coronary angiography, where can be in the ER, ambulance, referring hospital, or CCU. Any place before getting the patient in the cath lab is a pre-treatment with P2Y12. This story of pre-treatment in the cath lab has very long time. And once we started to put a stents inside the patient, the first 7 stents deployed, or the first 7 patients had stent deployed, 4 of them had stent thrombosis. This means if we did nothing for without any treatment for the patient, we may have 50% risk of stent thrombosis in the deployed stent. Then the question was there, this was very early days of PCI. Then could we anticoagulate patient with heparin followed by warfarin? And this worked. And stent thrombosis was decreased by, now it was to 5 to 10%. Then surprisingly, one of the registries found that the combination of aspirin and cyclopidine together made the stent thrombosis much less. And then compared, when they compared the results of aspirin and warfarin together in black versus aspirin and cyclopidine in white, the results was amazing for stent thrombosis and for myocardial infarction and revascularization. And we felt, yes, we did it. Now we can found a solution for stent thrombosis. And that time, patients started to be loaded or pre-treated 48 hours before being taken to the cath lab. And over the last 20 years, what happened? Cyclopidine was replaced by clopidogrel, and more potent antiplatelets are there in the market. We have ticagrelor and prasugrel, although it's not available in the Saudi market. But pre-treatment with P2Y12 inhibitor remained one of the basic concepts in the cardiologist's mind and in all guidelines. Then recently, this year, 2020 guidelines update. What happens? We had a clear recommendation for pre-treatment with DAPT in the recent European Society of Cardiology guideline, which is in red. What is this recommendation? It's not recommended to administer routine pre-treatment with P2Y12 inhibitor in patient whom anatomy is not known and early invasive strategy is planned. And this is class 3, this is contraindicated and level of evidence A, very strong recommendation. Do not pre-treat, or in a better words, do not routinely pre-treat if you do not know the coronary anatomy and you are planning for early invasive management. Why? Pre-treatment with P2Y12 inhibitor may be considered in patients whom are not planned to have early invasive strategy, and patients will not have high bleeding risk. And this is not a strong recommendation, it's 2B level of evidence C. So this is a grade downgrading in the pre-treatment in the world of acute coronary syndrome. So what are the options of P2Y12 inhibitor in the European Society of Cardiology guidelines? It's either prasugrel, which is class 1B, ticagrelor class 1B, clopidogrel, which only if other agents are not available. As regards the onset of action, the onset of effect of the available P2Y12 inhibitors, we can compare clopidogrel, the onset of action after 2 to 6 hours, it's really delayed, or prasugrel from 30 minutes to 4 hours, which is rapid, or ticagrelor, which is fast, it's from 30 minutes to 2 hours to have the onset effect. So this was a reassurance for cardiologists from the European Society of Cardiology guidelines that when we are using the recommended potent P2Y12 receptor inhibitors, ticagrelor or prasugrel, they have a fast onset of action, allowing the loading dose administration after the diagnostic test can be recommended. And you can give it directly before PCI and it will work. But we as Cardiology Society, how did we react to this downgrading of the pre-treatment? It's very strange. Should we believe that? Should we stop pre-treating patients after being given this treatment for a long time? Actually, the answer came in the guidelines recommendation. Although the rationale for the pre-treatment in acute coronary syndrome may seem obvious, and actually it's logic, for achieving sufficient platelet inhibition at a time of PCI, large-scale randomized trials supporting the routine pre-treatment strategy are lacking. It's logic to pre-treat patients, but do we have really evidence supporting this recommendation? And according to the general rule, if you do not know, randomize, and this is what happened. So let's explore the evidence of why shouldn't we pre-treat patients. The first evidence was this trial, a COAST trial. This was published in New England Journal of Medicine in September 2013. It was a trial for pre-treatment with prasugrel in non-ST segment elevation, acute coronary syndrome patient with non-STEMI for prepare for coronary angiography within 2 to 48 hours. And patient randomized either to be pre-treated or not to pre-treated with prasugrel. The primary efficacy of thrombotic endpoint had no difference between the patient received pre-treatment or did not receive pre-treatment. And for a major bleeding, the pre-treatment that the patient received pre-treatment had more major bleeding, either CABG or non-CABG related, compared to the patient did not have pre-treatment. And in conclusion, they found that pre-treatment with prasugrel did not reduce the rate of major ischemic events up to 30 days with increased risk of major bleeding. In simple words, the pre-treatment to give the medication, the dual antiplatelet early upon admission, was associated with higher bleeding risk. And this is expected. You are giving antiplatelets. But the unexpected was that the pre-treatment had no significant effect on the rate of major ischemic events over the 30 days period study. And the editorial for this paper was this with this title, P2Y12 inhibition in patients with non-STEMI can later be better. And actually cardiologists started to think, can we give our pre-treatment later? Could it be better? Because it didn't work in this trial. Another registry, which is very prestigious, a SCAR registry from Sweden, they just published the same recommendation. They found in this registry that among more than 60,000 of patients pre-treated either with 40% almost pre-treated with clopidogrel, almost 50% pre-treated with ticagrelor, and small numbers pre-treated with prasugrel. So do we have difference or any value when we are pre-treating our patient? The conclusion came as follows. that the pre-treatment of patients in non-STEMI with P2Y12 inhibitors was not associated with improved clinical bleeding. So the same, the SCAR registry showed that there is no benefit, but there is harm of pre-treatment. A third trial, which is a REACT-5, again, randomized patients to either ticagrelor with pre-treatment or prasugrel without pre-treatment. And they found that the strategy of prasugrel without loading dose, except after knowing the coronary anatomy, was superior to ticagrelor-based strategy with routine pre-treatment for the patients. And by this recommendation and by this evidence, I guess it's time to say goodbye for routine pre-treatment in the world of acute coronary syndrome. If the patient, we do not know the coronary anatomy, and early invasive strategy is planned within 24 hours. Another question, and this question was addressed by Dr. Samih Lawand in his previous presentation during STEMI. So what is the case with patient with acute coronary syndrome non-STEMI? Actually, the duration of dual antiplatelet therapy in cardiology. Some believers that shorter is better, some believers and lots of evidence supporting longer is better. So which is the best? Before telling the best, we have to settle the general rule. While the whole guidelines we have by European and national guidelines following PCI for non-STEMI acute coronary syndrome, dual antiplatelet therapy consisting of a potent P2Y12 receptor inhibitor in addition to aspirin is generally recommended for 12 months irrespective of stent type. So it's 12 months as a general rule with aspirin plus potent P2Y12. And this is the graph from the recommendation guidelines that it is +1 level of evidence A with very strong references. You have Plato, your 38 trial. So the evidence of this times, DAPT duration can be shortened, can be extended or modified by switching dual antiplatelet during the course of the treatment, depending on the individual clinical judgment, because patient may have bleeding, may have evidence of another ischemia, may have side effects, there is comorbidities, another medication the patient is taking, or that's very simple, the patient may not have the drug available in his area. So every rule has exceptions. So what is the evidence and the recommendation to shorten the dual antiplatelet therapy? Actually, after stent deployment in a patient with high bleeding risk or precise DAPT score more than 25, discontinuation of P after 3 months, which is 2A level of evidence B. In other words, after stent deployment to stop aspirin can be after 3 months. And this depends upon the balance between ischemia and bleeding. Is this the same like the previous? No. In the previous recommendation, which is 2A as well, you can stop the P2Y12. So you stop dual antiplatelet after 3 months and continue on aspirin. This is 2A. Or to stop aspirin and to continue on the P2Y12, it's again can be recommended 2A recommendation with lots of supporting trials. Not only that, in patients with very high risk of bleeding, or the patient had urgent surgery, the patient can be on only 1 month of aspirin and clopidogrel can be considered, and this is class 2A as well. So these are the options to shorten. What about the options to prolong the dual antiplatelet therapy. This is the new updated recommendation that to prolong antithrombotic treatment, and let's go through them. Adding a second antithrombotic agent to aspirin for extended long-term secondary prevention can be recommended. It's class 2A, level of evidence A, very strong recommendation for patients with high ischemic risk. How can we identify these patients in whom we should prolong the antithrombotic treatment, and how can we find the balance between the bleeding and thrombosis? The answer in this table. Patient with high thrombotic risk for whom it's class 2A, you get extended use of second antithrombotic includes complex coronary artery disease plus one of the following, only one of the following, plus complex coronary artery disease is making the patient eligible for long-term treatment. What are these risk factors? Diabetes. We have lots of our patients have diabetes, recurrent myocardial infarction, any multi-vessel disease, any polyvascular disease like coronary artery disease, peripheral vascular disease, cerebral vascular disease, premature or accelerated atherosclerosis. All of these plus advanced chronic kidney disease, all of this plus complex coronary artery disease can get this patient high thrombotic risk. And some technical aspects as well, like patient with 3 stents, patient with 3 lesions, patient with stent length more than 60 milli, and patient with complex PCI or patient with a stent thrombosis on top of antiplatelets. All of these criteria, if you have only one of them, plus complex coronary artery disease, this patient will have a high thrombotic risk. So, how should we give a long-term antithrombotic for our patient? We have either to go with prolonged dual antiplatelet therapy, and the options are including aspirin plus either clopidogrel 75 milligram, prasugrel 10 milligram to reduce to be 5 milligram if the patient is less than 60 kilogram or patient is older than 75, ticagrelor 60 or 90, preferably 60 milligram according to Pegasus trial. These are the 3 options plus aspirin to give a prolonged dual antiplatelet therapy. But this is not the only option. There is another option recently updated in the guidelines to give a dual antithrombotic, including aspirin plus rivaroxaban, the vascular dose 2.5 milligram, based on COMPASS trial. To whom who did not know this COMPASS trial, this is a very important trial, a very positive trial, and after that we have this recommendation to have dual antithrombotic agents, aspirin plus this rivaroxaban small dose. And this puts us in another dilemma. So when we prolong the antithrombotic, should be dual antiplatelet or dual inhibition, dual pathway inhibition, aspirin plus rivaroxaban. If we get confused, and because the recommendations are plenty, we have shortened, we have many options, we can go through this graph provided by European Society of Cardiology guidelines. When you have a patient with low bleeding risk, in green, you have option of 1 year, and this is the rule. You can give aspirin, prasugrel, aspirin, ticagrelor, aspirin, clopidogrel if you don't have prasugrel and ticagrelor for 12 months, and this is the basic. Or other option, you can give for 3 months aspirin, ticagrelor, and then you can stop and go on ticagrelor monotherapy if you have any interest about reduce the bleeding. If the patient has high bleeding risk, 3 months of aspirin clopidogrel can be enough, and then continue on monotherapy with aspirin. In very high risk, you can reduce up down to 1 month of dual antiplatelet therapy. In a simple graph done, I did this graph to make things more simpler. The all patients or the standard 1 year of dual antiplatelet, it can be 2A recommendation, the bleeding risk is high, to stop at 3 months, and then you can either go with ticagrelor alone or aspirin alone according to the bleeding, or if the patient has a very high bleeding risk, you can have only 1 month of dual antiplatelet therapy. It's class 2A as well. If the patient has, on the other hand, high thrombotic risk and the patient completed 1 year of dual antiplatelet, then you can continue or prolong giving the patient either dual antiplatelet or dual antithrombotic, and this can be 2B recommendation if the risk is only high, not very high, like the 2A recommendation. Then another option, switching between P2Y12. Is it an option? Yes. Patient may have bleeding, and then we are changing from the potent to less potent antiplatelet. Or sometimes non-bleeding side effects like dyspnea or ticagrelor, like some allergic reactions to clopidogrel, or the patient cannot get the ticagrelor because of the economic factors. So when we have these factors, we should consider switching between P2Y12. In other words, DAPT de-escalation, or the concept of de-escalation, means that to switch from a potent drug like prasugrel or ticagrelor to a less potent drug, which is clopidogrel. And according to the guideline, the de-escalation of P2Y12 inhibitors can be considered a class 2A when the patient deemed unsuitable for a potent antiplatelet inhibitors. And this can be on the clinical judgment, platelet function testing, or genotyping. And there are many ways to have knowledge about this P2Y12 switching, and one of them is this very good consensus paper published in Circulation 2017, how to switch between P2Y12 inhibitors. And don't forget, our guidelines still recommend the potent antiplatelets, and potent means ticagrelor or prasugrel. And they mention clearly that uniform means that for all patients, de-escalation of P2Y12 receptor inhibitor therapy after PCI, especially if early in the first 30 days, this may be with the cost of increased ischemic risk. The sample conclusion of all we discussed in our work, one size never fits all, and individualized decisions, and not only individualized, a dynamic decision should be there. We may discharge the patient with a plan, and then we found the patient is having bleeding or having another polyvascular event, or the patient did not tolerate the drug by reason or another. So individualized and dynamic decisions should be to shorten the dual antiplatelet, and if we shorten, we keep patient on single antiplatelet, should be aspirin or other agent. Should we do de-escalation of the patient after 1 month if the patient cannot tolerate this potent P2Y12 inhibitor? Should we prolong dual antiplatelet therapy after completing 1 year? And should we give the patient aspirin, rivaroxaban, small dose? All of these options can be studied during the journey of the management of the patient. My take-home message: antiplatelets are cornerstone in the management of non-STEMI acute coronary syndrome. Use of potent antiplatelets is strongly recommended by the local and international guidelines unless contraindicated. Ticagrelor showed superiority against clopidogrel in patients treated invasively or medically managed patients. Routine pre-treatment with P2Y12 inhibitor is class 3 nowadays. It's contraindicated for patients whom coronary anatomy is not known and plan for early invasive strategy. And duration of dual antiplatelet should be decided according to the balance of bleeding and thrombotic risk individually. And thank you very much.
So thank you, Dr. Muhammad. This was a wonderful presentation again. So I'm going to go ahead and read you some of the questions that did come up from our audience. And, one of them is what we're living in right now, the COVID era. And although the kingdom, the numbers are slightly climbing again, but technically we still haven't really had our second surge. How do you think we should be managing these non-escalation MIs? Should we move into a second surge? And what have we learned from the first surge in terms of streamlining these patients who are going to go to the cath lab and so on?
Actually, what we learned from the first surge is to be more reasonable in dealing with troponin leak. So if the patient in the ICU and with COVID and has troponin leak without no clear evidence of acute coronary syndrome like chest pain, it could change. Sometimes patients have COVID and myocarditis. So being reasonable not to push such patients to directly to the cath lab and treating them conservatively, it works. And I think this is what we learned in the first surge. Till now, luckily, we have still controlled numbers of COVID. So our management nowadays in our center is the same. If the patients are admitted with acute coronary syndrome, risk stratification or is there, most of the patients are treated invasively within 24 hours, except if the patient have this ongoing chest pain or very, very high risk, then they are dealt with immediately in the cath.
Right, and the other issue which you did touch on but keeps coming up in the questions is, the abbreviated dual antiplatelet regimen. So when would you choose a shorter DAPT? The data or the verdict is not completely out. And a lot of the studies actually look at high bleeding risk patients, but are not looking at the average patient. In your practice, what do you think? Who are the patients that you wouldn't hesitate in stopping dual antiplatelet early and continuing with only single antiplatelet?
It has multifactorial, but the most important is the bleeding risk. If the bleeding risk is there, and it's very good to use routinely the precise DAPT score or DAPT score, whatever you like, to identify these kind of patients. If the score is high and the bleeding risk is high, we should consider 3 months enough for dual antiplatelet, and then we can continue on single antiplatelet therapy. But for the rest of the patient, for routine patients, for simple procedures, 12 months is still the rule. 12 months is indicated not only for the stent, it's to treat the vulnerability of a patient with acute coronary syndrome. It's not only the stent we deploy, because even in medically managed patients, still the recommendation is 12 months of dual antiplatelet. So my personal decision is, if the patient bleeding risk is there, we will go with less potent dual antiplatelet. We'll take a clopidogrel and we'll try to be at 3 months, maximum 6 months, and then continue on aspirin alone. But for the rest of the patient, especially for younger patients, for patients with polyvascular disease, patients with diabetes, complex intervention, left main intervention, 2-stent bifurcation, these patients usually we think not only to shorten, we think of to continue the dual antiplatelet therapy for 3 years and maybe for longer than this, or to get the combination, which is aspirin, rivaroxaban, vascular dose, which is again vascular protective as well.
For Samih, maybe I'll turn to you. If you choose to put a patient on monotherapy, so single antiplatelet, which one would you choose?
I would like to look at it from a different aspect. It's probably much easier to recognize the patient at higher risk for bleeding, but it is more difficult and less obvious to the general performer to recognize the higher risk for ischemic burden or thrombotic events. In that term, technical aspects related to the procedure, the so-called sizing, the length of the stented segment, and there's a say about what we call a 60 millimeter stented segment, whether it is continuous or not continuous, may represent the higher risk group. That's on one side. The other risk group are the ones whose stents are inappropriately deployed, either undersized or allowing the so-called target area to be partially uncovered by the stent with what geographic miss, what we call, is also another element of higher risk. So if I take these technical aspects of the procedure related to the number of stents or length of the stented segments, number of vessels diseased, and the technicality related in the acute setting when there is high thrombotic burden, where under deployment of stents is likely to occur. Taking all of this, I would select the patient whom I know that the stented segments is less than 60, that the overlap segments are minimal, that there is no bifurcational stenting and crowding of stents at the junction, at the carina, and also whom I know that the operator has had a so-called a history of perfectness or near perfectness in doing their procedure. And it's more difficult. I respect that, but it has to be, this is why most of my patients may go into the extended periods rather than the shorter. Those who I recognize that they have a bleeding risk, in any way I do, whether by history or by actual happening, then it's a completely different story.
Yeah, I agree. And I think that what's being recommended now is to gauge our PCIs through intracoronary imaging. So for patients who have had intracoronary imaging, we're happy with stent apposition and expansion and so on. It may be more encouraging when we have that kind of information to, abbreviate our DAPT sooner. And I also appreciate what you said, that ischemic risk is not easy to pick out, particularly that what renders a patient high risk for bleeding also renders them high risk for ischemia. A lot of these factors are actually very well overlapped, and it does become difficult. And the final thing I'm going to say is a lot of the studies, short of the meta-analyses that pool data from different randomized trials, actually don't look at the number one issue that as interventional cardiologists were concerned about when we stopped dual antiplatelet, which is stent thrombosis. A lot of them, the number of patients enrolled the studies are not powered to give you that, because the event, stent thrombosis per se, is a very low occurring event. So unless you're really powered and it's a very large study, it won't show it to you. Only pooled data gives us that kind of information. And so, yes, I'm like you, tend to be very reluctant to stop it unless my patient is definitely a high bleeding risk patient. Dr. Muhammad Abdullah, what are your thoughts on radial access? I know Dr. Samih presented it as part of the Stemi, that it is a recommendation to use radial access. I know the European guidelines have already added that based on trials such as the Matrix and so on, but the Americans are still a little reluctant, given that the number of operators that are doing radials is still not really exceeding 50% of the operators in the US, believe it or not. So what do you think our region is like?
I think in our area, luckily, we are more going to the radial intervention. And honestly, our results with the radial intervention is better than the femoral. Once we are pricking the femoral artery, we are expecting troubles. And whenever we are giving patient, if indicated glycoprotein to be 3A or any other strong antithrombotics, the bleeding is there and the complexity is there. So I think whenever the center is radial experienced, I think the radial, in both the guidelines and in our national guidelines and in our national experience, we believe that the radial intervention saves life. We believe so.
Absolutely, I agree with you. And I think we should be moving more in the direction of radial access whenever possible. The only thing is, once we look at a lot of these trials that actually compared radial and femoral, it's the non-access site bleeding, in fact, that was higher. So it's difficult to explain. Nevertheless, the data is what it is. The bleeding was less with the radials, although, as I said, I know personally I tend to be more aggressive during the PCI, I'm more liberal with 2B3As and so on when I'm radial access.
Maybe this is why.
Yes, absolutely.
Feeling remorseless, not, it's not going to happen, but it does happen.
Yes, true. Well, thank you, gentlemen. Very, very informative and very thorough presentations. Thank you to Saudi Heart and Kunuz Ritaj for this invitation and for very well organized. The attendees who stayed with us, I think we've got quite a number of them with us this evening. So thank you and hope this was helpful. Inshallah, في ميزان حسناتكم وصدقة جارية من علم الآخرين. شكرا والسلام عليكم.